To our fourth Meet the Finalists webinar. I'm Joy Shepherd from Chamberlain Dunn, with the organisers and creators of the Advancing Healthcare Awards, which highlights the work done by allied health professionals, healthcare scientists and those who work alongside them. For the past 15 years, these UK-wide awards have highlighted the often overlooked contribution of these professions. And by now we should have celebrated our 2020 award winners, but this year the awards ceremony has been postponed until the 16th of October, which will now be a virtual ceremony. So please do join us for that. And it does seem a long time, I have to say, since the judging day back in February. So thank you for your patience, all of our finalists, in waiting to hear who has won. And so during the gap, it's given us time to focus and have a think about some of the work that our community has been doing during the COVID crisis. And from this, the Esteem recognition scheme was launched, and really since the end of April we've been blown away by the nominations that we've received from every corner of the UK, from every profession, each one all rising to the challenge, going above and beyond. And all of that is now available to look at on our website under the Esteem Awards, and please do visit it because it's really inspiring, and I'd encourage you to please share with colleagues across your professions and networks. So, and also before we get going, I'm just going to mention our green publication, which was part of the awards. We asked all our submissions to the entries to tell us what they were doing to sort of improve the green aspects of their services. And this award was in association with DEFRA, and we have a publication now which collates all of those projects and also tells us who the winners were, and you can find that also on the website. So today we're hearing from the finalists in the Viapath Award for Innovation in Healthcare Science. It's an award about scientific initiatives which have helped transform services. And we're delighted that Dr. Dominic Harrington can join us today from Viapath. He will be our chair, and he's going to introduce the speakers and lead the discussion. So over to you, Dominic.
Thank you, Joy. Very pleased to have the invitation to be here this afternoon. This is the third year that Viapath has sponsored the Award for Innovation in Healthcare Science. Providing and supporting healthcare has always been so much more than a purely transactional endeavour. And this is because in addition to delivering the immediate healthcare of today, healthcare scientists must also anticipate and inform the healthcare of tomorrow. So it's probable that precision medicine, point of care testing solutions, the increased integration of patient information will all continue to play ever more prominent roles as we work our way through the third decade of the 21st century, which of course has got off to the most difficult of starts for all of us. So I was therefore delighted to see that each of these themes are well represented by our three shortlisted finalists this afternoon. So let's begin. It's my pleasure to be able to introduce the first of our three speakers, Lauren Wise, Senior Biomedical Scientist, and Stuart Adams, Trust Lead Healthcare Scientist. The project originates from the Molecular Minimal Residual Disease team based at Great Ormond Street. Lauren and Stuart will be telling us about the development of a method for high throughput sequencing for the analysis of paediatric diagnostic leukemia samples. The analysis supports the molecular detection of minimal residual disease to personalised stratification of patients to the appropriate intensity of chemotherapy. We will hear how novel methods like this identify suitable diagnostic markers, even in cases where traditional screening has proved previously to be unsuccessful. Lauren, Stuart?
Hi everybody, thank you for shortlisting us first and foremost, and I'm a bit of an interloper in here. It shouldn't be me presenting with Lauren, it should actually be Gary Wright, who was the head of the department but has since retired, and Ellie Watt, who unfortunately is sick today. But Lauren is a key member of the team and is happy to present the nitty-gritty of molecular MRD in paediatric leukemia. And so I'm just here really as an interloper to just blow their trumpet on their behalf and say how wonderful this work is, and also because I've had a chance to speak to clinicians and doctors at Great Ormond Street, and so we've found out the impact it's actually had on patients at the other end. So I'll hand over to Lauren, and we've got a few slides to show. There you go.
So good afternoon, everybody, and again, my sincere thanks for shortlisting us, and I hope you enjoy hearing about the work we do here and enjoy it as much as I do on a daily basis. So I'm just going to talk about the development of a new method to identify paediatric acute lymphocytic leukemia biomarkers. I might use the word biomarker or clone, sort of either or, but they're essentially the same thing. So acute lymphoblastic leukemia is the most common cancer in children, of which 360 cases per year are diagnosed in the UK, with standardised treatment pathway, chemotherapy that is given over a course of 2 to 3 years. But as Dominic has mentioned, this new novel method that we're now using has helped us in risk stratifying our patients, because the treatment pathways are totally dependent on these laboratory results. So we don't want to blanket treat the patients. Each patient, each child is individual. The medicine they receive is personalised, and the biomarkers that we then identify, or clonally identify, will then ensure that we get reliable, reproducible results at each treatment time point, of which we have at the moment 3 potential time points post treatment that we follow very intensively to ensure that the way that the patients are being treated is correct. Because if, of course, the patient, the child, is over-treated, then there could potentially be further malignancies later on in life, or even, in the worst case scenario, fatality. So survival is good at this point, but it's not perfect, and there's 86% cure rate. And we would hope with our method that in majority of cases that children are diagnosed with ALL will, at least on the molecular level, have biomarkers that we can reliably help follow them throughout the course of their disease. So molecular MRD, I'm going to give an overview of what we used to do, and then what we're doing now, and a little bit of the limitations of the previous method, and why did we even move on to next generation sequencing. So we would receive a sample, normally it would be bone marrow aspirate taken from the patient that is full of blast, so the leukemic cells, the malignant cells, whether it be B or T cells. So we would then extract from that bone marrow aspirate DNA. We would then run PCR, this polymerase chain reaction, so with a concoction of primers that are specific for the clonal markers that we're looking for. Previously, these PCR products, at the end of the PCR, would then be run on a gel. It was very labour intensive, exposing lab staff to potentially hazardous chemicals. They didn't want to be using this. It was having to take those bands from the gel, which you can see there are specific clones, having to then take them from the gel, purify them, and then run them through an analyzer using Sanger sequencing. First of all, do your cycling PCR beforehand, so it's quite labour intensive. Sanger sequencing is not as sensitive as we well know in the lab field as next generation sequencing, so our clones do need to be particularly high. And in next generation sequencing, we actually get sensitivities down to less than 5% in cases where normally Sanger sequencing would not be able to detect those whatsoever. So we're getting patients that potentially also have low blast counts. So we put those into next generation sequencing and we do get results. And after the sequencing, or now obviously with the next generation sequencing, we'll do our primer designing, which is specific for the biomarkers. We will then run testing to ensure that each assay is reliable. We would ideally like 2 assays that are reliable, sensitive and quantitative down to a very low level, so that we can then actually detect what we call minimal residual disease, which is sub-microscopic levels of disease, much below that of active disease, which would be, more than 20%. In the diagnostic sample. So we're looking down to 0.01% in the patient sample. So I'm just going to talk through these 3 panels on the slide. I don't know why I'm pointing, because you can't see my fingers. But the top panel is what we would have seen previously in a gel. But those specific bands, which I hope you can see, are 3 specific clones. So we would see that, or biomarkers in the patients. The middle panel is what we would see from a Sanger sequencing plot. So the bases are fluorescently labelled, and then we're obviously looking through and we're comparing it to our germline, our normal, and then we're trying to decipher which clones are going to work for us, or that we can then design assays for. But the two that we see here that we've actually drawn arrows to, we wouldn't have necessarily called clones, or we would see that they're just, the size of the sequences are just too close, we wouldn't be able to distinguish them. So what we're highlighting down below is that now we can see that there is two distinct clones here. So we may have even been following one over the other, but they're two distinct clones that have their own sequences and their own assays that can be performed. So below is what is from our visual analysis, our bioinformatic platform that we use to analyse our sequencing data. And it shows we have two distinct clones here, very large, and you can see that in comparison to the background, which are the smaller clones there, we wouldn't necessarily look to design assays for those, but those two larger clones we would, because they're at a level that we would be able to say with confidence that we could then follow later on. So yeah, this is just a description. The bands cannot be resolved following Sanger sequencing, so the high throughput sequencing is able to distinguish those clonal populations. And over to you, Stu.
So am I right? Just think each one of those dots represents a patient clone, and each one of those clones is totally unique to that patient.
Yes, yeah.
So each patient has their own bespoke assay made for each clone.
Yeah.
And you'll never see that clone in another patient.
No, no.
Okay. So this project started back in 2016 when we had a PhD student called Jack Bartram in our lab, and he did the groundwork alongside a team in Bristol who are experts in this field, and also a genomics expert who's now at the Marsden called Mike Hughbank, to get this up and running, and they published this as part of his PhD. And it's expanded since then. So I've been lucky to be part of the follow-up work we've done from the patient perspective. And the disease, leukemic disease, can sometimes manifest in the spinal fluid as well. And previously, this was almost impossible to track due to the low cell numbers in the spinal fluid. But follow-up work using this methodology showing that disease can be detected in the spinal fluid at extremely low levels, and this is really important because it needs very different treatments when it's just based in the bone marrow. And a final paper from Gary right here and Ellie, who are not here today to present this work, so I'm here showing off for them. They went back and analysed a whole cohort of patients who were unable to be diagnosed and tracked successfully, and applied their new method to it. And in every single case, it was complex, every patient case was complex, but the new approach was able to decipher and identify the cancerous clones in these children. And actually, had we known that and had this technology at the time, then it would have saved lives. So we now use this as our first choice gold standard, and we're working with other laboratories to ensure that they can also have access to this technology. And so Bristol are now already doing this, and that we're hoping that other labs will follow suit. That's our last slide. But I'm going to just ask Lauren a few questions, and I know the answers to these. So this is this is just provoking your thoughts on how it's been through COVID.
Oh, yeah, the whole COVID situation has obviously been unprecedented for all. We've been working throughout, which I'm sure everybody in the NHS has been, but we've seen an increase in samples, and the diagnostic samples came sort of after lockdown, so a lot of the diagnostic samples we were getting through were very, very high level diseases, of which we were having to get them through very quickly, and then the data engineers were coming in, majority of them were risk, very early on, which we weren't used to seeing. So COVID has had a massive impact in the diagnosis for those patients. We're getting a lot of follow-ups, of course, And we're also taking on some extra work from other trusts that were focusing on adult cases of COVID because they needed more capacity in the hospitals. So therefore, we were taking on some other adolescent, young adolescent patients. So we also have a lot more patients coming through from other trusts. So,
yeah, so I think the press have touched on this, haven't they?
Yeah.
That patients are getting diagnosed later than they would normally because of the pandemic, and so that follows through that. So that's all we've got. So we're happy to take questions.
Great, thank you, Lauren. Thank you, Stuart. Absolute pleasure to hear you present your work. Can we just have our screen back so I can see if there's any
You might.
questions?
There we go. All yours.
Perfect. So first of all, I invite anyone who's listening to any questions out there. And if they're not, I don't know if they're questions or comments really, but I'll get things started. The one thing that really strikes me is that it's such a good example of a sort of good marriage between academic interest and then you guys being able to translate that into something that's benefiting patients. And the other thing that I'm mindful of often is that this translation could not have happened if you didn't have a supply of highly skilled individuals to do the work. So my question is really, in a team as specialised as yours, what's the abundance like of the skills you need? Are the people out there, or is there an enormous amount of training you're having to do to skill people up?
From my perspective coming in, so I've been here just over a year now, I had experience in the hemonc field before, and I did have NHS experience. However, I have learned a tremendous amount in the year that I have been here. The training has been absolutely amazing, and I've learned on the job a lot. And I think if people have transferable skills, if they're enthusiastic and they're keen to learn, and they have some idea of what we're trying to do here, then I think there's a lot of people out there that, you know.
And I'm going to give a big shout out to the apprenticeship scheme, which I'm a big fan of. And going forward, I want to see higher level apprenticeships for my existing pool of scientists, because I think, as exemplified here, who's a PhD student, who's an academic interest transferred into the clinical arena. And if I can engage my own staff into a PhD apprenticeship programs, A, I can keep them longer, B, I can upskill them, and C, they may benefit the NHS in the short and long term.
Yeah, absolutely right. And again, it comes back to the point that the service you are providing will never be a purely transactional service where you're just filling orders. You have an enormous amount of innovation still ahead of you. So all credit to you there. And the other thing is that it can be difficult sometimes when you've got people in a lab developing something as wonderful as this to link it tangibly with the patient at the end of it. How do you do that? How do you remind the scientists that what they're doing is helping families?
Do you know what? I've actually, since I've come here again, this is from my experience, I've never found it difficult. I always treat each patient with the care and the skill that they deserve. And also, even relapses as well, we're getting a lot of relapse patients in the last 6 months. You're having to go back to their original samples, you're looking at the sequencing for their original samples. It's very, very hard for us to not be constantly reminded of that patient and those families. We actually have a lot of interaction with the clinicians as well, which is actually a really good thing. I think that it's something that, although we're not patient facing, the clinicians can, on the patient and family's behalf, you know, do them justice.
I think we tailor the way that we work our systems to what the patient needs. So I'd encourage staff to go to clinics and see what's happening at the other end.
Yeah. Good on you. Any other questions before we move on to the second speaker, something? Ruth?
Always with a question. Fantastic. It's so impressive. I'm so amazed at the work that you've done, and so, I'm really emotive as well, because it's, you know, children who are very poorly, and I think that's, you know, it's fantastic that you can work into that space. My questions are nearly always the same, which is around how do we share the good work that you're doing out into the wider system? So how do we showcase what you're doing there for the rest of the system to see how wonderful scientists are doing? That's my selfish one. But also, how do we share? I can see you've published a paper, which is great, but how does that paper become meaningful to other scientists up and down the country?
So it's quite a niche thing, this MRD in these patients, and there's a European network. So everything that we do is shared with the European network. And as we said, we didn't do this in isolation. We worked with Bristol, another paediatric centre. And we're hoping to, we're open in sharing our methodologies with other laboratories, and we encourage them to take on board this. So we're hoping when the pandemic is over to have staff from other labs in our lab to try and get them running without being patronising.
The consortium is really good. You know, the European consortium had the pleasure of going last November to Belgium to, you know, we were there for a few days, and everyone was talking amongst each other, and everyone was really, you know, sharing a lot.
Especially over a beer.
Yeah. But I think that's the wonderful thing about it. Everyone's so willing to share and give their 2 cents, give their opinions. But I think that's the great thing about it, being part of that consortium.
Great, well done. It's really, really good. Thank you. Thank you, Dominic.
Great question, Ruth. Thank you very much. So thank you, Lauren. Thank you, Stuart. We'll move on to our second speaker in a moment. And just remind people that if you want to ask a question, you can use the chat function as well. So feel free to post your questions on there. So let's move on to our second speaker this afternoon, and that's Anna Stec, who's a healthcare science fellow at NHSE and I. Anna is a clinical engineer, and she will be telling us about a pilot point of care testing project to generate a diagnostic result for Streptococcus A in a timely manner in the community setting, so that appropriate treatment can be implemented within a single episode of care. Now, this isn't an esoteric problem. I hadn't realised that approximately 1.2 million people visit their GP every year with a sore throat each year. So how do we make sure that the right patient gets the right treatment at the right time? Well, Anna's going to tell us. Anna.
Hello, everyone. Thank you very much for this lovely opportunity to speak to you today, and thank you so much for the nomination. My name is Anna Stec, and I'm a healthcare scientist working in clinical engineering. I'm specializing in all aspects of medical technology. As already mentioned, the aim of my project, or our project, was to utilize expertise of healthcare scientists to facilitate a development of new patient pathway in community pharmacy. And that was to improve diagnostics of bacterial streptococcus in sore throat and optimize antimicrobial prescribing. My role as a healthcare science fellow at NHS England and Improvement was to lead on the progress of the project. And my colleague, Dr. Madi Borhani, who's also a clinical engineer, was the project manager for our project. So we clinical engineers were working within a team of pharmacists, driving a development of new patient pathway and implementation of this new technology, which is quite a innovative approach, really. Next slide, please. So to take you very shortly, just summarize what we've achieved over the last 12 months. I will speak shortly about the drivers behind the project, what we've achieved, and COVID impact on the project. So to start with the drivers, antimicrobial stewardship was one of those. And that's about optimizing antimicrobial prescribing, so how we use antibiotics, and to optimize how we use antibiotics by using new rapid diagnostic technology. Another driver was the new pharmacy role that comes with pharmacy contractual framework that talks about moving pharmacists from dispensing to offering new services for the patients, and that is to reduce pressure on the primary and urgent care in the system. And finally, the last, I guess, one of the most important drivers was about sustainability agenda. So obviously NHS is trying to minimize carbon footprint of the services we provide. And one of the achievements of our project was that we were able to design into the evaluation a process of this pilot, calculating carbon footprint of the new service compared to what we do already, which I was really excited about. But other achievements, we can count the establishment of multi-disciplinary group of stakeholders. We had over 25 experts from different disciplines, and our partners, I've mentioned them in the orange box on the right-hand side, on the bottom of the slide. And through work with those stakeholders, they're using their expertise and linking with what they do, we were able to develop community pharmacy consultation service functionality for patients so that they could use telephone to link with our service in the pharmacy. We were able to develop collaborative approach with Wales, who already have a sore throat test and treat service, and see how we can do things together, possibly in the future. And we also delivered a governance structure for the project and service, which spans from business case for the project and medical technology evaluation report to service specific that we shared with commissioners and training materials that enabled us to train pharmacists in Tower Hamlets, where our pilot was supposed to be launched. And finally, there was assurance process that we've also established, and that was through reporting with our colleagues across the network, across the system, and some of them are mentioned on the left-hand side on the bottom of the slide. But then in March, our project has been put on hold, and that was due to COVID-19, obviously, and members of our resources teams of our, or members of our team have been redeployed to more urgent tasks, responses to the COVID-19, obviously. As part of the distancing measures, we had to risk assess our service, and we had to admit that with the shortage of PPE at the time, we couldn't really safely provide that service in community pharmacies. The throat swabbing was not safe without the PPE or with the distancing measures that we had to take. And finally, with the COVID-19, and remember that back in March, one of the symptoms of COVID-19 was sore throat. So that kind of put us in a situation where we were questioning if the clinical assessment tools and resources that we were supposed to be using that are recommended by NICE, if they are still valid, that maybe they should be revalidated, and we will potentially be putting patients at risk. So the decision has been made to put the project on hold. But there were other things that I was doing. So I've been redeployed to help as incident response manager, where I was managing teams to operationally support emergency preparedness, resilience and response teams in London and the national team. I was also working as part of London Region Healthcare Scientists team under the our scientific director, where I had chance to contribute to providing scientific advice to the national team on deployment of nationally procured ventilators, if you remember. So my expertise as clinical engineer came really handy when we were advising on requirements for the medical equipment and also any potential risks and barriers of using those in the circumstances that we were facing. Another thing that I was able to do and contribute in those difficult times was supporting healthcare science workforce lead in the recruitment, training and deployment of healthcare scientists and engineers who wanted to volunteer at Nightingale Field Hospital in London, which was a great opportunity. And finally, quite surprisingly, I was asked, I was headhunted and asked to help and work with Education Council on developing content for a new healthcare scientist related qualification called T-levels, which I found really, really fascinating and really rewarding role. So that's what happened since March. And then around May, June, we started to think, well, can we maybe readapt our service in community pharmacy and see how we can maybe change it so it's more appropriate in the environment where we are now. So some of the opportunities which we were exploring was to offer self-test for patients at home to test themselves for sore throat, and then have video consultations in the community pharmacy or GP. But when assessing benefits against risks, we're still really worried and really nervous about second wave in autumn that we were told that, you know, is a highly possible situation. The use of PPE, I mean, there was access to PPE, but when to think, is it ethical to use PPE and take it away from the front staffing in NHS? And the answer is probably not. So we didn't feel really confident to do so and to progress with that. And finally, there was more and more questions around COVID-19, and does it have any relation to strep A? Someone who has COVID-19 and sore throat, could they not have strep A? How do we distinguish? What do we do about? So there's so many things that we still don't know. So we decided that at the moment we will still keep that project on hold and will not progress with it. So that's the situation at the moment. The project still hasn't relaunched, but in the future we know that we will go that route, and we want to relaunch it and reactivate. We'll probably wait for the vaccine to be available to make it safer and more manageable. We also think about linking what more different ways we could link this service to testing for COVID-19 going forward, maybe with schools reopening. You know, there's so many different scenarios when we could think testing for strep A, for sore throat, but then also COVID-19. Another thing, we're very closely looking at Welsh sore throat test and treat service, because we know that they are actually relaunching. So we want to see what's going to happen, you know, what benefits, what risks, what happens when you have that service versus when we don't have it here in this country, and how does it impact antibiotic prescribing in England versus Wales. And if the decision is that it's still dangerous and not appropriate to relaunch our service, we will look at refocusing our attention and implementing point of care testing in community pharmacy, but maybe thinking about different infection and how we can change it and readapt and benefit some other areas and some other patients. So that's all from me. Thank you very much. And do you have any questions?
Thank you, Anna. Any questions on that talk? Thank you very much. I only have some very general questions, actually. So some of the common challenges with point of care solutions include things like, how do you monitor the performance of the test, external quality assurance, and things like this? Have you given much thought to that?
Yes, absolutely. So there's different products out there, from very simple ones where you can perform simple quality assurance yourself. But obviously going forward, and if that was to a successful pilot, and you would like to expand it across London, or maybe try it in the different regions in the country, absolutely we'll have to establish some robust quality assurance mechanism so that we know that it actually does what it's supposed to be doing. Absolutely.
Yeah. Absolutely. So training is one challenge, isn't it?
Yes.
Assurance is another one. And the other challenge can often be, how do you get the result into the patient record and things like that? So have we looked at that?
So as I said, because we started thinking about it really early on and thinking how we can really implement this service within primary care. So thinking, how do we send those results to GPs? Yeah. So having that community pharmacy consultation service, so when we can pull the data, patient data from the central database and then send it to pharmacists, it won't be that difficult to then have it electronically sent back to their GPs without any additional admin time required to process the data. So we thought about it already. I think that's a key requirement to make it work and make it beneficial rather than extra burden on the staff. Absolutely.
Thank you. So I'm looking for questions. I'm looking at Ruth, because Ruth is a question factory.
It's called an inquisitive mind, Dominic.
Oh, that's what I meant. Sorry. Yeah.
No, they're generally leading questions, actually.
Yeah.
I think this was also going to tick the antimicrobial resistance piece of work, which is a bigger piece, which I think is also kind of being put on hold, but I've seen a few papers now. So how is this linking back into that? Are we tapped back into the driver for this, which was AMR and the top of the food chain, Anna?
Yes, absolutely. That's a very good question. And the thing is that we're not trying to prescribe more antibiotics by introducing this service. It's the opposite. And it's about giving that confidence, robust training and resources to the pharmacists so that when patient doesn't need antibiotics, they can provide education for the patient so they can understand what the risks of taking or misusing antibiotics is, and to share that knowledge across our population, really. So yes, so we were working with Health Education England to see how we can, and Public Health England as well, about leaflets, education materials, but also to expand on the modules for the pharmacists so they can learn and feel really confident about saying no to the patient, but also what comes with it is the education, that information.
One other question, if I may, Dominic, and that was not around this piece of work that you've done, Anna, but more around the point of care testing, community pharmacy, say of UTI and other areas where we know that there are products already out there in community pharmacies such as Boots. Have we taken that any further? I'm actually finding out now.
It's a very good point. It's really about, it's a difficult question because private companies or private healthcare services in the country are always quite quick to adapt all these new technologies, and there is the question, we're national services, we should probably catch up and try to offer similar services to our customers free of charge, possibly. But with UTIs, for example, that's why we have this fantastic team of really engaged stakeholders who know how the current system and pathways look like. Is it appropriate to come forward with that kind of development at this time? And I think specifically with UTI, because the pathways are now redesigned and reviewed, we really closely look at it, and we want to be involved and engaged from NHS England and improvement point of view. But it's to really start talking about at the right time, not to spread any confusion, or really invest in pilots when it's not appropriate, when the pathway is not clear, and when patients are difficult to follow up. We want to help, not to introduce any further complications and difficulties for the healthcare providers.
Okay, thank you, Anna.
Thank you.
Thank you, Ruth. Thank you, Anna. So let's move on now, if there's no further questions.
Thank you.
You're welcome. So now it's my pleasure to introduce our final speaker this afternoon, and this is Jack Stancel-Lewis, who is a Healthcare Science Fellow for NHS England. This is a pre-recorded presentation from Jack, but Ruth, of course, is here, who co-produced this project and is available to answer any questions at the end of the presentation. And Jack will be telling us about the sensory health passport. So you may not know that in excess of 75% of older people living in care homes in England have a hearing impairment, and around 50% of individuals have a visual deficit. So sensory deprivation can impact an individual's well-being, causing communication barriers, and may also increase the risk of cognitive decline. At the moment, care staff tend to rely on memory to identify who requires what sensory aids. And you can imagine how this system of relying on memory could fail. So Jack, if you'd like to tell us, please, your project.
Hi there, my name's Jack. I'm an audiologist, healthcare scientist, and I'm completing a fellowship at NHS England that is aimed at improving access to sensory health across London. And I'm working with Ruth Thomsen, who's the head of healthcare science in London, and she's also an audiologist, healthcare scientist by background. So our project is the Sensory Health Passport. And I'm going to talk to you today about some key statistics in the area of hearing and vision loss, look at the aims of the project, what we did to meet those aims, spread and adoption of the passport, and also look at how COVID has impacted our project. So, sensory input is the fuel for cognition. This is a quote by Professor Adrian Davis, the world-leading authority on hearing. We know that as we age, sensory impairment increases, the proportion of sensory impairment increases in the population. We know that sensory impairment increases the rate of cognitive decline and is a potential risk factor for dementia, specifically hearing loss, but dual sensory loss increases that risk even further. And we know that a large proportion of our care home residents have either a hearing loss or a vision impairment. And we also know that generally other long-term health conditions take priority over these conditions because of a lack of awareness of the importance of vision impairment, and also a lack of awareness that actually managing one's sensory loss can actually improve individuals' dementia-related behaviours, reducing agitation and confusion in some cases. So what did we want to do with our project? We wanted to improve residents' well-being, we wanted to increase the awareness of sensory health in care homes, ensure that the sensory needs of residents were met not only in their care home but also in the hospital setting. And we linked in with the red bag scheme that meant that, that means that the bag is packed with all of the belongings, but there's anecdotal evidence to suggest that once we get to the hospital setting that hearing aids may not be put in, they may stay in the bag. We also wanted to empower care staff to manage sensory needs. So what did we do to meet those needs? We created the Sensory Health Passport, which we produced in a co-produced manner, which meant that we involved individuals with a lived experience from the patient public voice community, and creating that because they're the real experts in this area. We implemented some sensory awareness training, and we collaborated with the third sector, the voluntary sector for this, specifically the Jewish Deaf Association, who went into our care homes and delivered the training. And we also appointed sensory health champion role within the care homes for these individuals to take ownership and disseminate the information out between staff. So this is a picture of us and some of our patient public voice community, and this is from some of the people that were involved in this project and a different project. And I really like this photo because you can see everyone's really happy, and I think that's because we're all working towards something that we're really passionate about, and also have the same goal in mind. So this is the Sensory Health Passport. The purpose of the passport is to act as a memory for care staff that actually this individual needs hearing aids or glasses or magnifying glass. It acts as a memory about how to communicate effectively with individuals with either a vision or hearing loss. And also it should be systematically filled out and updated with the care plan as we move forward. Excuse me, sorry. We did this in a sort of easy read manner. We included pictures to ensure that if the carer's first language was not English, it was slightly intuitive and would help them identify when to change the battery, which glasses or magnifying glass or assistive visual aid they need. So this is us running some of the sensory awareness training, and here you can see that our care champions are wearing glasses that will imitate specific types of vision loss, and this is to enable them to understand and get an understanding of how certain visual impairments or sensory impairments may impact their residents and how they may need to adjust the way that they communicate with these residents. So we run a pilot study. We did a multi-centred pilot study of 3 different care homes in the London Borough of Barnet. We trained 9 champions and 96 passports were issued across the 3 homes. So to evaluate this project, we did some semi-structured interview with our sensory health champions and care home staff, care home managers, and we identified 2 key themes about the passport: the usefulness or how helpful the passport was. See some of the quotes to the right that back up that statement, and also the information was easy to find when using the passports. Further thematic analysis around the training. So we identified 3 key themes around the sensory awareness training, and that it improved timely care, it increased the confidence of the care staff, and also improved the job satisfaction of the care staff as well, which is really important, specifically in a sector where there's high staff turnover. And we know that job satisfaction and confidence ultimately will improve patient care as well. We did a non-validated but peer-reviewed survey as well that looked at individuals' confidence at identifying residents having difficulty communicating, their ability to change batteries in hearing aids, tighten up screws, clean glasses, but also again looking at the job satisfaction. We saw that all staff reported that learning these new skills improved their job satisfaction. So moving forward from there, as a team we engaged with the local CCG and health authority and implemented a workshop with some of the commissioners and presented some case studies. These were developed by both Andrew and Louise, and we spoke about how not having hearing aids and vision loss can impact residents in care homes and how important the project and the work that we're doing is. And we had some really good buy-in from the CCG. We also presented a poster with some of our results at the British Academy of Audiology, again trying to spread and adopt the work that we're doing. And then COVID hit. We've got Andrew Goodwin here on my right, and we've got Louise Keane on the left. And they've been working tirelessly throughout the pandemic. Louise was managing a care home ward up in North London, and Andrew's been going round to different homes and also people's personal homes, repairing hearing aids in the absence of NHS services running, ensuring that, you know, residents and other individuals are able to hear, you know, if their tubing gets blocked or if their glasses need tightening up. So that was really key. Louise identified actually 2 key points during her time working on the care home ward. That one, people's hearing was, you know, people couldn't hear and they didn't have the correct aids to manage that. And 2, their feet. That was another observation of hers. I'm just going to put my mask on. Now there you could probably see that my mouth was moving, but you couldn't hear what I was saying. And this is an added impact that the COVID pandemic is having on individuals with hearing loss and also visual loss, because, you know, it makes it more difficult to read facial expressions and small nuances of facial expressions, like when I smile, my creases in my eyes, I get creases around my eyes, and that might indicate that I'm smiling. But if you don't have the glasses that you need, you won't be able to see that. So Louise was continuing to implement passports across the care homes, and Andrew, as I said, was doing the repairs and assisting care homes as well. And the champions continue to also repair and manage the residents' sensory needs in-house, as there was no NHS services at the time. So we got some patient feedback, and as we can see, you know, it meant that the patient said she didn't need to cause a fuss because they knew that she needed hearing aids or glasses. And also a point here where, since the hearing aid had been fixed, the patient had been able to hear their grandchild for the first time. And this is obviously really important during a time of social isolation and shielding for some of our elderly care homes. Nurse feedback that complimented the care plan well, and they commented that it went on to A&E staff who reported that it was helpful. I think I heard that the passport didn't come back, so there may need to be some work that needs to be done there. So on here, driven by Louise, we are making virtual bite-sized chunk sensory awareness training and for nurses and also care staff, and how to fill out the passport. So this is something that we've been doing and finalised about a couple of days ago, so should be delivering it soon as part of the care partners in North London. And we know the conclusions, there's an incredible sensory need, greater need more now than masks, as you saw. There's a gap in the current service. We know that removing barriers improve residents' quality of life, improving carer job satisfaction ultimately will improve care and also improving their confidence. And this was an innovative, collaborative way of working. And we hope that it has a legacy, because actually, if care homes can manage sensory needs in-house, know how to communicate with people, then if there is further pandemic spikes, you know, it means that these residents won't be without their sensory aids. So we've met some key policy drivers, and these are some of them here. I won't go into too much detail because of time. I just want to acknowledge all the other contributors: Andrew Goodwin, Louise Keane, Jean Strauss, Jane Hopkins, Poonam Sharma, Sonia Fleming, Chris Ramdu, Hemna Sentiali, and Adrian Davis, and also acknowledge the care homes and residents that also took part in the project. And just a big thank you to all the carers that have been working through the pandemic, because without them, you know, we'd be in a lot worse off position. Thank you very much.
Great. Thank you much, Jack. And thank you, Ruth, as well. So Ruth's here to answer any questions. And if we have any questions for Ruth, now's the time to ask them. I just have a couple of things I'm sure you've been asked many, many times before, Ruth. So one of them is, I've never understood why hearing loss has always been overshadowed by visual impairment. Is that, am I right to say that?
Yeah, no, Dominic, I hear what you're saying. It's something that, as an audiologist, I think it's because we can emulate vision loss by closing our eyes and understand what that's like. Whereas emulating hearing loss is a more difficult thing to challenge, to sort of experience, but also personally, but also the hearing loss that we get due to the aging process. So that's very much, it's not a loss of hearing, say, completely. It's a distortion of what we were hearing, and that is the challenge that we face with older people as we try to amplify sound, but at the same time try and give them clarity back. I think the other piece is that the support for vision is dealt with in a very different way. It's a transactional support, it's a high street offer. So it has a high level and driver nationally in terms of how we work with it, because it's a commission service and there's money involved. Unfortunately for hearing, it sits in that really, really difficult space where it's not medically led, it's scientifically led, it's led by audiologists, but it doesn't have a voice at a national table. And as we've seen through the pandemic and through other areas, and as we know as scientists, if something's got a medical leader at the very top, then they've got a really strong voice for their condition or for the area that they want to progress. Unfortunately, we don't have that for hearing. It's a kind of Cinderella service. So generally what drives change in our space are the patients, their voices, and the third sector, and they're experts at that. And in a meeting today with the CSO, again, I was lobbying to try and improve the leadership of this area, and their response was, Ruth, 80 to 90% of our parliamentary questions in the CSO office are around hearing and hearing loss. It is a big concern. We don't have leadership properly in that space, but what we do have is a groundswell and working with the people who can actually make a difference at the bottom of the food chain, so to speak, when you look at our organisation. Yeah.
Thanks, Ruth. Great answer. The other thing I was looking for was feedback from the patients themselves, which there was some in there. Oh, so before I do that, I have a question from Stuart.
Hi, Ruth.
Thank you, Stuart. Thank you.
And obviously, it's a really good example of a low-cost, high-impact solution to improve patient care. And the pilot looks amazingly successful. So where do you go after this? How do you get this to move from pilot to on a national level?
The next space. So again, a lot of lobbying for me for there to be some sort of oversight across the national team in leading for hearing, because it sits in the CSO office, but it isn't an allocated leadership role. So taking a kind of, you know, political viewpoint from this, using the patient voice, the collaborations that we work with in the co-produced world and the charities, to drive the agenda and the desire for change. So as you saw, the Jewish Deaf Association was supporting them in writing business plans to roll out what they do to a wider community across Barnet. The GP who's been involved is now a fellow working into the Royal College of GPs. So we're working with the Royal College of GPs, talking about this to try and get an appetite for it at a GP level, so that they can influence into the care home. So it's a strategic approach, but a bottom-up approach, because currently there isn't anyone to help drive it top down except myself.
Great. Well, thank you for the question, Stuart. Thanks again, Ruth. Please.
You were going to ask about the patients, and I have to just
I was pleased to see some feedback.
Yeah, so that was a question that came out when we had our interviews on the day, so to speak, and when we both just went, oh my God. So it was a very good challenge and a very good question, and we went back and got that data. So there's a little bit in there, but we have got quite robust data in that space as well. So thank you, Dominic, for that challenge, because it was a really good one, and we did go back and do what we could on that in that space. Also, Jack didn't talk about the work that he's been doing through COVID, and that's been phenomenal as well. He's supported the work in engineers, but he's also now working on a new innovation for hearing loss for children with learning disabilities and autism in care homes. And because they've all been thrown out of their residential schools back home, he's looking at a model of enabling parents to assess hearing in the home with children with learning disabilities and autism, and that's about to launch out through GSTT as a possible model that will work. So he's been very busy in that space too.
Great, thank you for the update. We are out of time now. I'll just finish by saying that the favourite slide from yours, Ruth, is the picture, I think, of your sensory needs champions.
Yeah.
And they all look so happy-go-lucky, and I know, having met at least one of them, they're formidable individuals. So disarmingly, really, yeah. So it must be great to have them on board. Right, so thank you everybody for presentations. A really fantastic short list of projects for the Viapath Innovation Award for 2020. So back to Joy now, I think.
So thank you, Dominic. Thank you for chairing that so well, and thank you obviously to all our finalists, to Lauren and Stuart and Anna and Ruth, and obviously Jack who provided the presentation. All those projects are really really interesting, and you know, listening at the end to Ruth and all of you, you can feel the passion coming through. And I feel like obviously these awards open both to healthcare scientists and therapists, and there's so much to learn from each profession that you can learn from each other's projects. Just listening to what Ruth was saying at the end about you know, how this can go forward. You know, there's so many our therapists out there, if they heard about this, you know, because they have so much contact with patients and carers, you know, I can really see the potential for this and for all the projects, and I really hope you get the opportunity to share all of your projects through the next few months and really promote them, because that's what these awards are about, and you know, we will champion you as well. So thank you for that. The webinar is part of a series of webinars, as you know, in the run-up to the awards ceremony, and the next one is the Northern Ireland Award, which is coming up next week on the 17th. All of these webinars are available on our website afterwards, so you know, please do encourage colleagues to go back. They're there for people to you know, as I say, share. This is the opportunity to share your work. Finally, just to say, obviously the winners will be announced on the 16th of October. Registration links will be going out soon so that you can join us for that. And as I say, I'm so sorry it's taken so long for us to get to announce the winners, but obviously in the circumstances we all know why. So just thank you again, everybody, for joining us. We really appreciate you taking the time, and yeah, good luck. Thank you.